thank you everybody for coming for one more session of Oncology Beyond the Obvious. We are interested in taking a closer look to see about more recent landmarks type articles to see how valuable that information is, whether it is robust, reliable, and how much of it can be applicable to the real world in the Indian context. And also, of course, other low and medium income countries. So we have gone through several topics, and now we are coming to something which is extremely important, and that is non-hodgkin lymphoma. And for that, we have three stalwarts who are going to lead most of the discussions. Dr. Amish is going to interview Dr. Reena Nair, and then Dr. Prasanth Ganesan is going to do the moderation, and finally Colonel Uday will give his expert opinion. So before we start with the proceedings, may I invite Dr. Amish Vora, who is my co-program director and who's been doing all the hard work to set these things up. Amish, can you share your thoughts on what exactly is the summary of the data that is presented in the publication that we are going to discuss today? Amish?
Yes, sir. Thank you. Thank you so much, sir. Kashish, can I have my first slide? Okay. So we always, in Oncology Beyond the Obvious, we always ask one question and we ponder over that one question for 90 minutes and try to come out with an answer which we can take for next 4 to 6 months. So the question today, what we are asking is, should we stop high-dose methotrexate as CNS prophylaxis in high-grade non-Hodgkin's lymphoma? To discuss this topic, we always select one paper. Next slide, please. And the paper we have selected today is from Blood 2021. And the title also is Single Route CNS Prophylaxis for Aggressive Non-Hodgkin's Lymphoma, Real World Outcome from 21 US academic institutes. Next slide, please. So it's a retrospective analysis. So for the first time in OBTO platform, we have selected a retrospective analysis, and we will discuss in detail as the time goes. It's a 6 years data from 2013 to 2019. Patients included are DLBCL, high-grade B-cell lymphoma, and transformation from low-grade lymphoma. Burkitt's lymphoma and CLL transforming into high-grade are excluded. All patients received single route CNS prophylaxis in addition to chemoimmunotherapy. Patients who received dual CNS prophylaxis, that is IT also and high dose also, were excluded. Patients who switched from one to another due to toxicity were included in the toxicity analysis, but were excluded from the primary efficacy analysis. Next slide, please. This is very interesting. I request all of you who are listening to this, go through last 10 patients or 100 patients of NHL you see in your practice and look at the patient characteristics, whether it is matching or not. So male sex was slightly predominant, less than 70 were more predominant. Majority of NHL had a good performance status. 16% had abnormal RFT. 38% patients had B-cell lymphoma. 31% patients LDH was normal. Almost 80% of patients had either stage 3 or stage 4 lymphoma. Next slide, please. This is very interesting. Extranodal sites involved were, so this is a first time. Remember, these are not relapsed lymphomas. Were renal or adrenal, testicular, breast, sinus or parasinus, and bone marrow. CNS IPI score also was included, and low, moderate, and high. Highest was moderate, that is 51%, and remaining were low and high. DLBCL was 67%, which is, according to me, is relatively higher than what we see. Cell of origin, again, GCB was 45% and non-GCB was 42%. Again, non-GCB in my practice is much lower compared to this. 27% of the evaluable had double hit lymphoma. 45% patient received DAR epoch. Now this has drastically gone down in my practice. Next slide, please. This is the primary reason we are discussing this paper today. There was no difference. I again repeat, there was no difference. Whichever way you have given CNS prophylaxis, either intrathecal or high dose MTX. Next slide, please. So they tried to do propensity score matched patients analysis. They have done loads and loads of analysis, and we can send the paper for people to read if they want. There was just no difference in whichever way you take this. Next slide, please. I am just reading out the conclusion of the authors because the final conclusion will come from all of you people. The real world analysis found no difference between intrathecal and high dose methotrexate in preventing CNS relapse in high grade lymphomas. Relapse rates among high risk subgroups remain elevated, and reconsideration of prophylaxis strategies in DLBCL and high grade lymphomas is of critical need. Future studies should focus less on the route of methotrexate administration and more towards the molecular features in risk stratification and other biologically directed therapies. Next slide, please. So we had, Parikh sir is, I'm thankful to you for allowing me to present the results of this survey, although this was all your work, sir. 89 responses we had in this survey we had taken before this paper discussion. High grade NHL, how many people routinely use CNS prophylaxis? 30% use in all patients, 13% do not use, and 56% used in select group of people. Next slide, please. How many use high dose methotrexate? 25.8% use high dose MTX routinely. 27% either use high dose or IT-MTX depending on the type of people. 41% always use intrathecal methotrexate. Next slide, please. And this is the last slide. When do you really change your real world practice? This was one question because today we are discussing retrospective analysis. 59% people said that I need level 1 RCT. 39% said no, retrospective is good enough. You are happy to note that. And with that, over to Parikh sir to take the proceeding forward.
Thank you very much, Amish. You set the background for the intense discussion, before which we will have the interview with Dr. Reena Nair. So now it is my proud privilege to introduce to you somebody who doesn't need any introduction. And that is Dr. Reena Nair, who we were colleagues together at Tata Memorial Hospital in Mumbai. And now, of course, she is head of medical oncology at Tata Medical Center, Kolkata. I admire her because she has, got single-minded attention to academics and research, and her teaching is immaculate. I remember the residents in Tata Hospital, paying rapt attention to whatever she was saying, whether it is in a lecture form or whether it is on clinical rounds in the wards. As far as research methodology is concerned, she is a well sought after regular faculty at the Accord workshop that happens regularly in Australia. And this is a 7-day residential workshop. So it is something that is very intense. And I'm sure that many of our juniors have actually benefited from her being the faculty at the Accord workshop. She has been instrumental in setting up the lymphoma registry in India, along with many other colleagues. And in fact, in the recent Frontiers journal, you will find that there are 5 NHL publications. 4 of them have been reviewed by Dr. Reena, and then she was given the honor of being invited to write an editorial on that. So this should leave no doubt in anybody's mind that the most real world experience in NHL is by none other than Dr. Reena Nair in India. And while I say that she's an international authority on NHL, she's too modest to accept that, and she says, no, I'm only limited to India. Another proof of how significant her publications are is that 1,768 other articles have actually cited her work. And I think this is one of the largest citation levels that anybody from India has. So with this brief introduction, I hand over to Dr. Amish Vora to conduct the interview with Dr. Reena.
Dr. Lalit Mohan Sharma just typed in chat box that Reena ma'am and Parikh sir are excellent teachers. Lalit, rather than that, I go one step forward. It's my honor today to, sort of on the same platform as both of them. Thank you, Reena ma'am, for joining us. It's actually a real honor and privilege. What Parikh sir said, I just wanted to add one more thing. That whenever I have doubt in terms of lymphoma, I pick up a call and talk to Dr. Reena Nair, which is nothing less than 3 to 4 times a month. And जब एक महीने में मेरा call नहीं जाता है, दूसरे महीने में Reena ma'am would always say, क्या हो गया Amish, all okay? And she's always helpful and to the point. So again, ma'am, it's an honor and privilege. Thank you so much. With that, we will start our today's discussion, ma'am, if you're ready.
Yeah, Amish, let me say one thing. Distance does lend enchantment to view, kind of, no? Distance has made us all grow really fond of each other. Huh? Thanks, Purvish, for all the nice things that you have said. Go ahead, Amish.
Thank you, ma'am. So, ma'am, as our ritual is, initially around 6 to 7 rapid fire questions with a rapid fire answers from you, ma'am. Out of 100 high-grade lymphomas, what you see in your practice, ma'am, how do you divide how many DLBCL and how many other high-grade lymphomas?
So very quickly, if you look at high-grade lymphomas, exactly as they have said, leave lymphoblastic and Burkitt's out. So it will be DLBCL and what we now know as high-grade NOS, or the high-grade with a triple or a double fish positive. It will easily be 75% would be DLBCL's NOS, and the remaining would be either the high grade, or very few would be actually transformations from follicular, CLL, and marginal zone lymphoma, which would be less than 3%.
So 67% in their paper and 70% in your practice is matching, actually, DLBCL. Ma'am, second question is, in high-grade lymphomas, CD20 positive.
I think we have lost Amish, which is not going to be an easy job.
So we'll just wait for a minute to see if we can connect again.
Yes. Okay. So this was, an invitation we got from Frontiers in Oncology about a year back. And they said they would like to have something that we propose, which we can do from lymphomas. And they had actually quoted an article on epidemiology of lymphomas in India, which we had written about 5 or 6 years back. And they said we would like something on similar lines. And that's the time we got together to say we don't have much lab data yet to show some, different kind of a research from our area, but we do have real world evidence. And if they were interested in it, we would be happy. So they kind of immediately agreed. And we got Dr. Lalit, Dr. Naresh, Sumit from TMH, and myself, Padmaj being the ISMPO secretary, joined us. So we all became kind of guest editors. We had about 20 odd abstracts from across the country. And we had written to most of the people who do a lot of work in lymphomas. We selected 9 out of them. We had, actually we selected 11 out of them. We had 9 papers which were sent all together during the course of the year. Tough editorial comments, repeated ups and downs, out of which 5 have been accepted, which is, I think, quite a good number for Frontiers in Oncology. And that does have a good, let's say, a high citation index. So we are quite happy with what we have recently.
Excellent. Excellent. Over to you, Amish. Yeah.
थैंक यू सर. सॉरी, मेरे को पता था ना कि आज सर और मैम दोनों मिलने वाले, बत्ती तो कहीं मिलनी चाहिए ना मुझे, तो उसके लिए ये इंटरनेट अनस्टेबल हो गया. ओके, सॉरी मैम, द क्वेश्चन,
second question
was in CD20 positive high grade lymphomas, how many are CHOP and how many are EPOC?
Okay, so I used to give a lot of dose adjusted EPOC, and I had great faith that patients who had, very high IPI, who had multiple extranodal sites, would definitely benefit from dose adjusted EPOC. More or less, our own results as well as a lot of literature from the international community now suggest that dose adjusted EPOC does not do too much to the de novo DLBCLs. So those 75% can be kept outside. We still have a gut feeling that in double hit lymphomas, it does make a difference. But if you see some of the more recent publications in the real world, it appears that even in double hit lymphomas, it may not be making too much of a difference. So I think R-CHOP has become the standard of care ever since 2020 onwards. Again.
This was 2013 to 2019, and that's the reason 45% had still DR-EPOC.
Yes.
And I agree with you, ma'am. It is going down slowly. So, ma'am, 3 questions I'll club together. Do you believe in CNS prophylaxis? One. Second thing is, which patients you give CNS prophylaxis? If you believe, answer is yes. And before giving CNS prophylaxis, do you believe in doing lumbar puncture in these patients, ma'am?
So I believe in giving CNS prophylaxis, especially to testicular lymphomas. To some extent, I have been a proponent of giving CNS prophylaxis to patients who come with paranasal sinus lymphomas. And after the CNS IPI came through, if somebody has a very high IPI and has adrenals and testicular involvement, then we do give CNS prophylaxis to these patients. To the large majority of patients, sometimes when I see tonsillar lymphomas getting CNS prophylaxis and all, I have to hold myself back. I don't do it in those patients. So I believe in giving CNS prophylaxis to very few patients, which comes to about less than 10% of the patients of DLBCL that we treat. And for prophylaxis, I have always believed that IT-MTX is a good prophylaxis in these patients.
Lumbar puncture, ma'am. Do you do lumbar puncture in all these patients?
Yeah, we do a lumbar puncture as a diagnostic entity. We do a lumbar puncture in all these patients because between giving prophylaxis and knowing that they are at risk for CNS disease, we would like to exclude the fact that they don't already have occult CNS disease. And so a lumbar puncture becomes extremely important in these patients at diagnosis, because if it is disease in the CNS, then I would like to treat them differently and not just give IT-MTX to them.
Lumbar puncture without flow and lumbar puncture with flow cytometry, ma'am. How many extra CNS diseases do you pick up percentage wise?
So since you're doing it in the very high risk patients, if you believe the literature, then they say that if you do just a regular CSF and a cell count, you would miss out 60% of the false, so to say, negatives. They would be false negative. And if you do an IPT, then the sensitivity of the IPT picking up CSF involvement is to the tune of 80%. I don't have much experience in that because we have just started this in the last, maybe 1.5 years. And the numbers are so few that it will take us time to actually generate our own opinion. But this is what the literature says.
Right. So, flow cytometry routinely, which I was not doing, and this is something new, and I will start doing and send you even just 1-2 patients, whatever we do. Ma'am, just last question before we move on to the paper. How many CNS relapses out of 100 patients of DLBCL do you see in your practice, percentage wise?
So we looked at, I will give you for the entire 600 patients in whom we have looked at the data. The relapse rate is about 3%. About 30 odd patients have relapsed in the CNS. Mind you, our data has the problem of a large number of patients not being evaluable for response. and having left the protocols, before the 8 months or 10 months, or for that matter in CNS lymphoma, that CNS relapse, the time period would be about 1.5 years. And so I don't know how to adjust for those who actually did not follow up, or who did not follow up after progression and actually died of CNS relapse at that point of time. So I need to have some statistical jugglery to be able to say what is the actual percentage, but as it stands now, it's 3%.
Perfect. So, 3% in whatever data available you have. If you miss out for the follow-up data, maybe 4% or 5%. I don't assume anything more than that it would be there. So coming to the main paper today, ma'am, thank you so much. As always, I say we learn a lot from you. Retrospective data from 21 US academic institutes. And if you see author, who's who of lymphoma are included in that. Jin ke paper individually hum log ne padhe hai, they all have been author in this. To me, when I read the authors, it looked so important. From your perspective, ma'am, was there a real need of doing this paper or this publication or this study?
I think this is an important paper. It is retrospective, but in this kind of scenario, the chances that we will get a prospective randomized controlled trial is an impossible thing. So we have to bank on this retrospective data. If you look at the statistical methodology, first disclaimer is I don't understand too much of it, but they have actually tried to do a comparison which makes the entire paper even more meaningful, at least in the table that they have shown that there was actually no difference. So I guess if you have the right statistical help, you can make some kind of a judgment even in a good retrospective data. And like I say, if the data is good, what you enter, you will always believe the results that come out. The collaboration by itself is huge, and this is something we must learn from them, because we would have similar numbers if we were to collaborate and have our data kept in a centralized software. So I do like what they have done very much, especially if you look at what was happening to our practice from 2015 onwards. We moved a lot towards dose-adjusted epoch, and slowly the high-dose methotrexate was becoming, rather a standard of prophylaxis in patients of DLBCL. And so this paper kind of puts rest to a lot of treatment that we were giving.
According to you, so this was the real-time need for coming out with this paper, and I agree with you that, ma'am. Just dissecting paper a little bit, ma'am. Inclusion criteria. It says that single route prophylaxis. Sometimes IT followed by high dose MTX also can be beneficial. Why exclude those patients, according to you? We could have included those patients in the paper.
Already, if you look at the numbers, it is kind of skewed towards IT MTX, more than 75% versus about whatever 20%. And these are very few patients, and by and large it is a change which has been made due to toxicity. So they would actually only kind of make the results even more confusing if you had to put them also into that propensity chart which they have made. So I think they have just tried to keep it clean, that this is the commonest practice. You use a single route, and between the two single routes, what is the difference?
Take your point, ma'am. Same primary endpoint was CNS relapse. And they have said either biopsy proven or irrefutable radiological finding also will be considered as CNS relapse. Do you agree with this, ma'am, or do you like to do biopsy in all your patients? Because CNS prognosis, we all know after relapse what happens.
Yeah, in practice, if you have been with the patient, you have treated the patient, you know it is a high-risk patient, and the relapse happens in the CNS at about, let's say, 6 months to 8 months, and it is irrefutable on the radiology, as you are saying, then I would not really insist, because that's the natural history of the disease, and we would not be surprised by that kind of picture on the radiological. If very occasionally you see these relapses happening, rather late, sometimes a single relapse may be at 3 and 4 years. And at that point of time, I would definitely like to have irrefutable biopsy proven histopathology to say it is lymphoma, and then treat accordingly, and not another CNS tumor over there. So that is the time when I would like a biopsy for certain.
So natural history of relapse, if it falls into it with the radiologist confirming, you would not insist on biopsy. That is what I
would do the CSF nevertheless in these patients
yes,
with an IPT.
You're so right. Half of the patient had leptomeningeal disease and the CSF was positive in that. Before we come to Dr. Reena Nair's perspective on the interpretation of results, ma'am, 3 questions I would like to ask. Little bias towards that. That is what I thought. 83.6% of the patient had, ma'am, at least one extranodal site. So if you combine one and more than one, 83%, ma'am, we don't see so many extranodal in our DLBCLs, ma'am. What is your take on that, ma'am?
So clearly it is an inclusion bias, because we are only taking patients who needed CNS prophylaxis. And so obviously these are, advanced stage patients, multiple extranodal sites. And with the advent of PET and most patients undergoing PET, even we find, a rather large number of patients who actually have extranodal diseases, which we were not picking up earlier. In the routine DLBCLs, if you see, you will have statistics like, a little more than half are men. Most patients would be in the median age of about 55 to 57 years in India. And we have about 50% in early stage versus late stage. Our B symptoms and patients presenting with B symptoms is still 50% in the most of the series that have been presented from India. And this is because patients go around a lot before they are actually diagnosed as a lymphoma, and a lot of them have taken anti-tubercular treatment for time. And that is one of the reasons why we see a lot of B symptoms. And extranodal, of course, is if you are doing PETs, you have about 50-50%. So 50% have pure nodal and 50% do have some extranodal involvement. So for this paper, it is because the paper is biased towards height. Otherwise, the proportions, even in the Western literature, is not the way it is in this
basically,
paper.
they selected the patient who actually received CNS prophylaxis. That's why there was a bias which automatically happened and which was expected. I get your point.
Expected, yeah.
So I think you have answered about the number bias, 75% on one side and 20% on the other side. I would not go into that. Non-GCB. Parikh study also brought out non-GCB, and this study paper is also coming out with non-GCB in a big way. Do you really see, ma'am? Because, I always learned that GCP and ABC and all these are more of cell of origin rather than actual practice outcomes. So do you believe in cell of origin, ma'am?
So I will say that cell of origin has set us in a particular direction for certain. If you look at the initial data, it is in the pre-rituximab era when we actually saw a difference in the outcomes between ABC and GCB, which most of our papers, including the ones we have recently published, and there is one from AIMS, which has actually looked at the cell of origin, and the outcomes do not show any difference. And the reason is because more and more we are now able to understand that there are some very good ABCs and there are some very bad GCBs. So we have to go at the molecular level, maybe choose the NCI classification from C1 to C5, and then see which are the actual GCBs versus non-GCB, or actually the molecular subtypes, which makes much more difference in the outcomes. So don't throw out cell of origin, but it has actually led us to the next path. So it is not the most, I wouldn't base my treatments on cell of origin at the moment, but it is leading us somewhere for certain in the future.
Thank you, ma'am. Why I asked that question? Because DAR report, we started with a bang, we are back to our job. Similarly, I remember NEJM article of GCB versus non-GCB, such a big difference, and now slowly it is coming to narrow. But as we learn, as more and more we try to learn. Result in one line, ma'am, from your perspective of this paper.
So the graph that you showed is the result. There is no difference in the single agent MTX prophylaxis versus high dose methotrexate as prophylaxis. And this is extremely important because we must realize that we create a lot of not only financial toxicities, but other toxicities when we start giving dose adjusted EPOC with high dose methotrexate. we actually may be worsening the outcomes if we look at dose intensity of the backbone chemotherapy in the bargain of putting methotrexate in between. So there is a paper which says you can give it at the end of therapy, and that of course is something that one can think of, but it just prolongs the treatment for the patients. And after this paper, I think we should feel more comfortable that if we have to give IT, even if it is to give it with dose adjusted epoch to patients of double hit or triple hit lymphomas, IT prophylaxis is good enough in these patients.
So I would ask the last question as Parikh sir has emerged on his screen, and that is a sign for me to, sort of, right. A few questions I think we will take during the panel discussion. Ma'am, today's point is very simple. Should high-dose methotrexate as CNS prophylaxis in high-grade lymphoma be stopped? And is this paper tells us that we have sufficient enough data, and based on your own data, that this is a practice-changing paper and we should adopt this?
So this paper kind of at least gives me a good feel, because I have always believed that IT-MTX is the prophylaxis and high-dose methotrexate is the treatment. So if you find somebody with CNS disease at the time of presentation, which is very rare in DLBCLs, high-dose methotrexate definitely has a place. And in somebody like, somebody with testicular lymphoma, or somebody whom you want to give prophylaxis and the patient cannot tolerate it. Some young patients just cannot take IT-MTX. Some older patients, you will find it extremely difficult to give the IT-MTX. In those patients, I would consider high-dose methotrexate. Otherwise, for prophylaxis, no. For treatment of CNS lymphoma, whether it is primary presentation with CNS disease or it is a CNS relapse, definitely high-dose methotrexate is a good drug.
Right. So first choice is always IT-MTX. Patient who can't afford, we can go to high-dose MTX. Otherwise, high-dose MTX should be reserved for CNS plus disease. That is what I get from you, ma'am. Thank you so much, ma'am. To me, this looks like a practice-changing paper because Reena ma'am believes in that. So I believe in that. And when Parikh sir, before you take over, the last question to you also, and ma'am, you have to be there in the panel also. Sir, this is a retrospective analysis, and 60% of our respondents said that they would want category 1, level 1 evidence before they change their practice. I'm not talking only of lymphoma, but as a retrospective analysis, are we right in deciding the practice change? To you, sir.
Right. So who does prospective randomized clinical trials? It is the person who, or the organization or the company who has the IP of the drug in consideration. So if the drug has been used once, landmark paper has been achieved, and regulatory authorities have given approval, then there is no further incentive for the company, pharmaceutical company, to do further studies. And I think for that reason, prospective randomized level 1, so-called level 1 evidence is what is dictated or required by the drug regulatory authorities for the first approval for the product. And subsequently, there is a lot of relaxation. So as an academician, as a person interested in a patient in the real world, many times there is no scope for a level 1 evidence, as has been mentioned. And I think real world evidence is more practical and more useful. So I'm all for real world evidence as long as it is something that is robust and reproducible.
Thank you so much. Over to you, sir, for further this thing.
So thank you very much, Amish and Reena. You've really, set fire to this program that we have. And now we will move on to the panel discussion, which is going to be moderated by none other than Professor Dr. Prasanth Ganesan. Prasanth Ganesan is a professor and head of medical oncology at JIPMER, and a very prestigious organization. He has, like Reena, he has a lot of focus on research and publications. In fact, his citations is almost as much as Reena. It is 1,095. And he has an H index of 16. That means each of his articles has been cited by 16 other articles. And if you look at the I-10 index, which is number of times his paper has been cited by more than 10 other publications, it is 28. So very impressive researcher, very dedicated academician. But I would also like to share a couple of things of what he was up to when he was a resident in AIMS, in New Delhi. Okay. He was a favorite of Dr. Lalit Kumar, obviously because he was a student. But the fact is, normally residents who are a favorite of one person are not liked by other people. He was very unusual in being liked by all the professors at AIMS New Delhi, and that is a big feature. The other thing is that his wife is an excellent cook, and all his colleague residents who were bachelors would always look forward to having his dabba and sharing some really juicy homemade stuff from there. And the third, of course, is that he doesn't want to let us know that he is a wonderful singer. And the next time that we have an opportunity to meet him in person, we'll make sure that he sings for us as well. So with this brief introduction about Prasanth, I should also mention the panelists, Dr. Reena Nair, who's just been interviewed, Dr. Dinesh Burani, who is a senior hematologist from Rajiv Gandhi Cancer Institute, Dr. Hari Menon, who is from Bangalore. He moved from site care back to academics recently. Dr. Rahul Bhagarwa, hematologist who everybody knows is very vocal and very prolific about bone marrow transplants. Dr. Ritu Jain, our very own, who's been there right from the beginning of this session. She's a medical oncologist and hematologist in Mumbai. And Dr. Ghanshyam Biswas, our very dear friend who recently came to Mumbai, and he is from Cuttack. Dr. Amit Upadhyay sent a message that because of a family emergency, he may not be able to join. So with these introductions, over to Prasanth for the moderation.
Thank you very much, sir, for a very kind introduction, and you told some things about me which I did not know myself. So,
how does Dr. Parikh knows that your dabbas have been taken by the bachelor?
That
colleagues?
I don't know, sir. That I don't know. That was
that secret.
True.
How did it come out?
But the last secret about my singing is definitely not there. So I don't know how that came. Anyway, so thank you very much, sir. It's a great pleasure and honor to be part of this meeting, sir. And thanks for choosing me to moderate this. As discussed just now, Reena ma'am is nothing short of a legend, and to be a moderator for this session, great honor for me. And we have a great panel, as was just described by Dr. Parikh sir, and we have Dr. Uday, Dr. Hari Menon, Dr. Dinesh Burani, Dr. Rahul Bhagarwa, Dr. Amit, Dr. Ghanshyam, and Dr. Ritu Jain. So what we are going to do over the next 40 to 45 minutes, we're going to ask the panelists about their own personal choices of CNS prophylaxis. So this will be an in-depth discussion of just one topic, as is the theme of this Oncology Beyond the Obvious meeting. And then we're going to briefly relook at the paper of which is the theme for today, and then maybe some more data in this regard. And then we'll try to come up with some definite kind of recommendations or suggestions for the audience in general. With this, I'd like to start with a case discussion. So we have a 67-year-old male who had a stage 4 DLBCL. A bone marrow was involved, multiple bones, liver lesions, GCB subtype. The FISH panel was negative for Mickel BCL2 translocation. LDH was elevated, IPA score is high, the CNS IPA score is also high. He was started on R-CHOP chemotherapy. So my first question to the panelists is, what would be your plan for CNS prophylaxis for this patient? Can I start with Dr. Dinesh Burani, sir?
I think the whole discussion is on this only. So everyone is confused with this paper. So we would have gone, go back to, is a 68 years, any contraindications for
just one thing here, can we just say, let's forget the paper for a moment. Before this paper came, what was your practice? Let's assume you have not yet seen this paper.
If there is no contraindication, we would have given IV methotrexate.
You would have chosen to use IV methotrexate for this patient. What about Dr. Rahul?
So Ganesh, never been a great proponent of high dose methotrexate. We just persisted with IT methotrexate. In our papers also, what we see is, in spite of knowing that these adrenal glands, tonsillar lymphomas, stage 4 diseases might develop a CNS disease, we gave high dose methotrexate a couple of years back, like 3 to 4 years back, and still people kept on relapsing in the brain. So there was no major difference between the IT-MTX and high dose methotrexate, just adding more toxicity to it. So we have just switched over back to IT methotrexate every time that we do. And the pattern is like 6 times they get IT methotrexate, and that's all. So never, I mean, a couple of years back, a great proponent of high dose methotrexate, but since there has been a relapses on high dose methotrexate and IT-MTX, so going back to the lesser choice between IT-MTX. So when you have the panel discussion, panelists, all the panelists have spoken over, more interesting would have been to know whether if you don't use IT versus high dose methotrexate, what are the percentage chances in a selective groups of having a CNS disease? Leave aside the testicular ones, leave aside the paraspinal masses, paranasal spinous, but just extra nodal stage 4 diseases. What are the percentage chance if you don't do anything versus you do something?
So we will come to that, Dr. Rahul. We are coming to that. So since you brought that up, can I ask Dr. Hari, what is your experience with CNS relapses? What proportion of your, we already heard Dr. Reena telling that it's about 3 to 4% probably from a very large database that she has. So what is your perception, Dr.
I would agree with what Reena ma'am's observation, because that's what we have seen, about 3 to 4% of CNS relapses, and even before we had this concept of CNS IPI. So just coming to the question of whether this particular patient I would have given 10 years ago, most certainly they would have received IT methotrexate. Then I was sort of enthused with the scientific rationale behind giving high dose methotrexate, given that most of the relapses were parenchymal, and so it just without any real data, we used to give high dose methotrexate to such patients, and we also had this CNS IPI which sort of helped us to take that decision. But I would agree that in the last few years, for all of us who give high dose methotrexate, we know how difficult it is to give it. The patient has to go through hell, and I think this current paper sort of helps settle in, not completely going away from high dose methotrexate, but being rather selective about using high dose methotrexate in patients.
So to make it short, can we all agree, or do all the panelists agree that this patient needs prophylaxis? We'll come to what needs to be given, but do we all agree that prophylaxis should be given in a patient whom I just showed with a high risk CNS IPI? Does any of the panelists would disagree with this? Okay, so we all agree that
Prasanth,
yeah.
Prasanth, Rahul this side.
Yes,
so
please.
the question is the basic question which even started between IT methotrexate and high dose methotrexate. If you go back into the literature, what is the difference in points? And Dr. Reena Nair is there. I'd love to learn from a vast experience. And Hari Menon is there, and Dinesh is there. They're the giants of lymphoma. If you do a prophylaxis versus you don't do a prophylaxis, what are the rates? Is that statistically significant for the rates of preventing the CNS disease? Because the whole idea is that we are not understanding the disease biology in a rituximab era, that one mutation which is leading to a breakaway to have a CNS disease, which neither IT-MTX, neither methotrexate is preventing it. So is it giving 6 poking into a spine in an R-CHOP patient, like DA Epochar has come back to R-CHOP? Does it make really sense in prophylaxing these patients? Of course, testicular we know is like going to be 100%. I mean, not 100%, 80% people are going to have a relapse. Because in our study, even if you don't give a prophylaxis, it's very difficult to predict, even CNS with a CNS IPI, who will get into a CNS, and that IT methotrexate really brings down the risk is what is the question. And Dr. Amish has searched the literature. In this paper, which they have seen, what was the percentage points which have been a decrease by giving IT-MTX versus high-dose methotrexate?
So yeah, this kind of generates the controversy that I think Amish wanted to create over here. Do we actually need to give prophylaxis in this patient is a good question. If you go by literature and you go 20 years back, let's say before 2000, everything was a risk factor for CNS disease. And that is because they used to put all the high grade lymphomas together. And we know that the Burkitt's and the lymphoblastic need the treatment and so are out. More or less in the last 10 years, we know that testicular lymphomas are not really diffuse large B-cell lymphomas. They have a very specific type. And at the molecular level, they are actually the primary CNS lymphoma-like diseases. And so they are also out because they need CNS. Beyond that, there is very little evidence to say that by actually giving the high-risk patients, we are actually doing something and preventing the CNS relapse. It is there is really no data that shows that by giving IT-MTX, we will actually be able to prevent in the kind of patient that we have just seen. If we look at data over time, it is very clear when we look at our 30-odd patients that there are patients of stage 1 who have relapsed, there are patients of low IPI who have relapsed, and there are patients, and the numbers are almost equal among the higher stage and the higher IPI versus the low stage and the lower IPI. So there is something we still don't know which puts the patient to the risk of relapse. And unless we find out that giving giving IT-MTX to almost 90 to 95% extra patients is actually an overkill in some ways. So we have to be able to find out the right patients. And if you look at the CNS IPI, then very clearly it says that the low risk patients have about a 3%, the high moderate risk has somewhere between 5 and 6%, and it is the high risk that have 11 to 12% in the various series that are there in literature. And so it may not actually be the prophylaxis. These are the patients who have occult disease, and it may be very important to find out the occult disease when we start treatment, rather than say we'll give CNS prophylaxis, and if they relapse, we say the CNS prophylaxis did not work, and if they don't relapse, we say CNS prophylaxis worked. So my own take is that we have been giving too much of CNS prophylaxis. If you look at the literature somewhere around 2002, they realized testicular paranasal is all that requires, and they stopped giving IT-MTXs, and most large series have less than 5% of patients getting IT-MTX. Whereas in our series, most of us, if we actually look, we would have about 25% patients getting prophylaxis. And so this is something that is, subject to debate. We can have everybody else's opinion. This is mine.
So I think, this is a very important question to whether we need the prophylaxis at all. I think part of the problem is, even though the relapse itself is only 5% of our patients, once they relapse in the CNS, we all know that the outcomes are extremely, extremely dismal. It's almost impossible to salvage a DLBCL even otherwise. But once they relapse in the CNS, it's almost end game. And the Western data suggests that person who relapses the CNS, the median overall survival is 3 to 7 months. So there is this inherent feeling in our mind that let's do something to prevent that CNS relapse, because we don't want that to happen. So maybe the urge to give something, and the ITM takes the least of that. Yes.
Prasanth, just to correct you, that those people who relapses today, their outcome is not that bad. So in our series of 10 patients, at a median follow of 4 years, almost 90% people are alive. People who came from other places with a secondary CNS relapses. So a matrix protocol followed by thiotaper, carmustine-based autologous transplant, and they have done well. So
that's very interesting, Dr. I don't have that kind of experience. So I mean, that's really encouraging to know that you are able to salvage.
Dr. Bhargav has to publish it before we confirm it.
I can send you 10 patients, Dr. Dinesh.
We need to publish it. We need to publish it.
Don't have time. Sorry, don't have time.
So we will keep moving.
Kind of give a short perspective over there. It is right that they do very badly with the standard of care, which used to be salvage chemotherapy. There is hardly any takers. there are some CNS relapses which happen late, not in the first 6 to 8 months. If it is 2 to 3 years later, and in those patients, if you do exactly what Rahul was saying, an occasional patient. I have only one patient who has survived for a long period of time. The ones which relapse quickly and in whom you can't take them up for salvage with and an auto transplant after that. Having said that, we must also remember what is the chance of our patients taking the second line treatment, and out of them, what is the chance of them going in for a treatment like this? It is rare, and very rare. So, if you're kind of in that situation where you're doing it, you will have your patients and the data outcome will be good. But what is the chance of our patients going in for something like this is also something we need to question.
I think the outcome will improve once the CAR T cells show the effect, and probably the CNS, the CAR T cell may change the outcome. Or the autologous, the people who are going for autologous, they reach to that stage, will have a better outcomes.
Well, Dr. Dinesh, Dr. Reena, just adding to it, the temozolomide and thiotepa has really made a difference in achieving a CR.
I completely agree.
That's all.
Just to again reiterate this. So we need a predictor of CNS relapse. So in the rituximab era, so the CNS IPI seems to be the best that we have at this point of time as a good clinical handle for this. So Dr. Ritu Jain and Dr. Ghanshyam, we can bring them in. So Dr. Ritu, do you routinely use this as a guide to direct your CNS prophylaxis if you use that, or use any other parameter for that?
So earlier, as I was trained under Dr. Reena Nair at Tata, so earlier I was just doing it for testicular lymphoma patient with paranasal sinus, and my choice used to be intrathecal methotrexate. I was not a great fan of high dose methotrexate, and especially in your patient, Prasanth, 67 years old, I would be worried about the toxicities and the treatment, the R-CHOP being delayed. And then in the era of rituximab, and we are giving rituximab to most of our patients, I really not convinced about the high dose methotrexate as prophylaxis. Now the question of yours that whether I do the IPI score for the CNS, earlier I was not doing, but recently I have started doing. But I'm not doing flow for everybody, it's only by the CSF cytology.
What about this? We know that high IPI is something, and we talked about testis definitely. What about, there are some people say that somebody who's got a breast lymphoma, got a higher risk of CNS relapses. Madam talked about the paranasal sinus involvement. Are there any other sites which you would be worried about or you would consider CNS prophylaxis?
So Dr. Prasanth, maybe paravertebral diseases, many times we see as spinal lymphomas, though it is rare, but yeah, so that can be one of those. So where we consider. So
do others agree to this paravertebral? Paravertebral is not uncommon. We do see patients with paravertebral involvement. So do others agree? Just because it's a paravertebral involvement, would you consider prophylaxis for that patient?
Prasanth, again, it's like a gut feeling, because we feel, it's a paravertebral, so whether we should give them CNS prophylaxis.
That's why I'm asking your this thing. There's no right or wrong. I'm just asking what people do. I don't always prophylax patients who have paravertebral involvement, but yeah, we do discuss this. So that's why I'm asking that question.
As long as the dura and the spinal canal is excluded, I mean, they're not looking like involved. Probably they're not the high risk for the CNS involvement.
I think this question is still a bit, not completely answered. Who needs the prophylaxis? So one guide is the CNS IPI, and of course the site testis. I think that's something everybody agrees about. Breast is something which is mentioned in the NCCN guideline. I have been, based on some of this, I've been giving prophylaxis whenever I see a breast involvement. Again, the data, as you all know, is very iffy for something like that. So that's where we have with respect to choosing the patient. Now comes to the next question. I think this is something which you're going to.
And also adrenal involvement is very high chances of.
Yeah. Adrenal and renal is part of the CNS IPA.
Yes.
The next question is, of course, IV versus IT. So IV is usually high dose methotrexate more than 3 grams per meter square. Of course, the pro is the greater parenchymal penetration, because many of the series suggest that the relapses happen in the parenchyma. But the con, of course, is that it's more potentially toxic, requires hospitalization, expertise, methotrexate drug levels. And of course, when you're trying to give it in between your R-CHOP, you can end up delaying your cycles of R-CHOP. Whereas intrathecal is something which we are all comfortable doing, less toxic, more accessible. But the cons are that there is minimal parenchymal penetration. And ideally, they say you should have an Ommaya reservoir, but we hardly use that. Fortunately, there is no prospective comparison of IV versus IT prophylaxis in the R-CHOP era. And so there is no unified standard of care. So that is the content of today's discussion. So again, going back to the question whether IT methotrexate really works, why do we keep using this? And are there some subgroups where IT works? Just wanted to show this data from the Recover 60 trial. This trial was originally a trial comparing R-CHOP 14 versus CHOP 14 from the German group. So in this trial, because of the use of R-CHOP, the CNS relapses came down from 0.9% to 4.1%. They did allow use of IT methotrexate in some of the high-risk groups, but in the patients who were treated with R-CHOP, there was no apparent benefit from IT methotrexate, with the possible exception of patients with testicular involvement. This was the secondary analysis of the study looking at the CNS relapses. So based on this, let's go into this question in a little bit more detail. So coming to the second case, the typical testicular lymphoma, 72-year-old male with no B symptoms. He's got a large 8-centimeter testis. He had an orchiectomy. And the PET scan prior to that shows enhancing lesion in the right testis, iliac lymph nodes, inguinal lymph nodes. Finally, stage is 2E, diffuse large B-cell lymphoma of the testis. This was an ABC subtype. E67 is 60%. He started on R-CHOP. So going back to the same question, how will you plan the CNS prophylaxis for this patient? Let's assume his renal functions are excellent and there's apparently no other contraindication for giving IV methotrexate, though he is 72 years old. So let's start with Dr. Ghanshyam.
Yeah, so I'll echo Dr. Reena ma'am's. So for me, in this subset of patients, so prophylaxis is always intrathecal methotrexate. So for IV methotrexate is for a relapse setting or a primary CNS level.
So Dr. Ghanshyam, there is this fear, or there is this concept that most of the relapses happen in the brain parenchyma in patients with testicular lymphoma.
Right.
So why at all would we give an IT prophylaxis in that? The IT doesn't go anywhere into the parenchyma.
Yeah, so that we can discuss, but so that has been probably a traditional teaching during this, and then coming back home in a peripheral center. So it was always a difficult task for us to give a high dose methotrexate. So that's why we never venture unless and until we are dealing with it.
So if it is feasible for you to give, if you have all the facilities for you to give, would you give IV methotrexate? I'm just provoking a discussion.
Okay. So probably so difficult to say at this moment. So
Dr. Hari Melon.
So we have been always comfortable with giving intrathecal methotrexate with testicular lymphoma, and for whatever it is, much of the data is associated with using intrathecal methotrexate, and so we continue to use intrathecal methotrexate. But this is one area where I was in when Dr. Savage was giving the talk on CNS prophylaxis once, and she said that this was one place where we might consider giving high-dose methotrexate post-completion of 6 cycles of R-CHOP, because it is primarily a prophylactic thing, and we are looking at trying to take care of the CNS. So, but I'm not too sure whether the IT methotrexate has really helped in the rituximab era, because it has considerably reduced the number of CNS disease. But again, it has not ever been looked in without IT methotrexate in testicular lymphomas. And as ma'am rightly pointed out, the molecular profile of a testicular lymphoma is more like a CNS lymphoma. They are always an ABC type, and they probably are completely different types of lymphomas, wherein they benefit with a CNS prophylaxis.
Does anybody want to differ from this? Would anybody want to give an IV methotrexate for a patient with this testicular lymphoma? So just last week, we were having an ASH update, and Dr. Ranjana Advani spoke on that. And that time she again brought this up and specifically mentioned this is one area where she would want to give IV methotrexate. So I don't use IV methotrexate for testicular lymphomas, just like what Dr. Hari said, always comfortable using IT methotrexate. But again, Dr. Reena Nair, your comments on this?
I'll just interject a little bit, but many of the testicular lymphomas which I've treated in the last 5 years, they have received IV methotrexate post completion of 6 cycles of R-CHOP. High dose methotrexate, sorry.
So definitely, when we forgot to give IT methotrexate way back in an occasional patient of testicular lymphomas, they came back with CNS relapse. So that is required. We have been comfortable using IT for the longest period of time as the route for prophylaxis. And more or less, if you look at the present paper, which Amish has been showing, there is a slight benefit of high-dose methotrexate in testicular lymphomas as compared to the IT. So if somebody strongly feels about it, yes, I think this is one area where one can think. But I have always been comfortable with IT. I don't remember so many testicular lymphomas relapsing in the CNS as we have seen over the time. But I think we need to take another look at all our testicular lymphomas put together who have received IT and then see actually what is the relapse rate in those patients. My own gut feeling will be the same. In some, we have missed the CNS as a sanctuary site just because we did a simple diagnostic LP, and it may not have been just testicular lymphoma. It could have had additional involvement of CNS, and those were the patients who relapsed faster.
So again, if somebody had to use IV methotrexate, this is a question of whether it should be intercalated or end of treatment. I think we've already discussed this, so I'll just quickly go through this. So this is just to show very recent data, which is presented in this ASH. So where they compared in patients treated with R-CHOP or like therapies, almost 1,384 patients, comparing end of treatment high-dose methotrexate versus intercalated high-dose methotrexate. There was absolutely no difference. The only other problem was that when you intercalate the high-dose methotrexate, there was more chances of delay. 20% of the cycles were delayed by a median of 8 days. And those delays were actually associated with inferior PFS. So if at all somebody wants to use an IV methotrexate, the best way to use it at the end of treatment, don't compromise your R-CHOP dose intensity. So there's no need to struggle and try to fit it in between your cycles. So coming back to the paper for discussion, so Dr. Amish had asked me to just go through this once more. So I'm just going to briefly take you through this.
Dr. Prasanth, one small query, if you could discuss. When we talk about in your patient number 2 of testicular lymphoma about intrathecal methotrexate, are we talking of only single agent methotrexate or a triple intrathecal, combining it with Arasi and hydrocortisone? So, opinion of the panelists, please.
Sure, great. Yeah. Can we start?
It's always.
Yeah. So, Dr. Hari.
No, it's always been methotrexate alone. We've never. I don't think we ever used a triple IT over here.
Prophylaxis is always a single drug.
So in some of these papers, I don't know whether I put that slide in. Some of these papers, there's been a mix of single agent methotrexate as well as methotrexate with Arasi, and some of them have shown that there is no difference between those two groups. I think we can safely say that we are going to use ITMTX. It's methotrexate alone at 12 milligrams. It's what most people have used. So this is the paper of discussion today. This is from 19 US academic centers. So as the who's who of lymphomas and the lymphoma centers of US are involved in this paper, and a single route CNS prophylaxis patients were chosen. So it's a selected group of patients of 1,162, median age of 62 years. ECOG performance tests excluding most of them. Most of them were high stage. 67% was DLBCL, 26% was high-grade BL, and out of which again 80% was double-hit lymphomas. 47% of them received R-CHOP, 45% of them REPOC. IT prophylaxis was given in 894, that is roughly about 77%, and 20% had high-dose methotrexate prophylaxis. This is the extranodal site involvement. As you can see, 69 of these patients actually had testicular involvement. We'll come back to that discussion later. So as has been already discussed, there is a slight preponderance of IT usage with higher age, which is understandable because you are less likely to use IV methotrexate in an older person. more patients with renal dysfunction received IT, more patients who got R-epoch received IT, and more patients with DHL and THL received IT. That's again probably because more of them received R-epoch. IV methotrexate is associated with testicular disease and more extranodal burden. So this is how the distribution of the patients was. The location of the CNS relapses, 64 of the 1,130 had CNS relapses. The median time was 7.8 months. So these actually the CNS relapse happens quite fast. And if you take the CNS IPI, the higher the IPI, the faster the relapse. So if you have a highest value, it is in 7 months, and the low IPI was 9.8 months. And with IT methotrexate is 7.5 months, whereas with high dose methotrexate is 9.5 months. So high dose methotrexate probably delays the relapses a little bit. It is not significant, but there is some more data on which I will show later. And what are the anatomical site of the relapses? This was available in 53 of the 64 patients. 22 were leptomeningeal, 29 were parenchymal. So a significant proportion is actually leptomeningeal disease. So it's not like all the relapses happen in the parenchyma. And 2 involved other CNS sites like ocular and spinal cord. This is the distribution. And again, the high-risk IPI was consistently showing high chances of relapse. It's similar to the original CNS IPI study, about 10% in the highest risk. So by prophylaxis, this was the primary finding of this retrospective study. Overall CNS relapses was 5.5%. It was 5.3% among those who got intrathecal prophylaxis and 7.1% in those who got IV prophylaxis. Absolutely no difference between these two. And whatever they try to do sub-analysis by age, stage, histology, cell of origin, LDH, double hit. So in none of these groups, the high-dose methotrexate made any difference. It was as good or as bad as the intrathecal methotrexate. And so they did further analysis to match the baseline propensity. And with all this complex statistics, again, the results are the same. There was no difference in the incidence of CNS relapse, whether you gave IT or whether you gave IP. So again, just to summarize, this was a very large retrospective analysis. They compared patients who got IT prophylaxis versus high-dose methotrexate prophylaxis, and they found no difference. Whatever matching they did, it is absolutely the same. And if you compare the predicted baseline CNS relapse risk weighted by the CNS IPI score, it's about 5.8%. And if you look at what happened in the study, it was 5.7%. So even if you compare it with what happens historically, there was no difference. So the prophylaxis itself, whether it made any difference at all, that is also something which is brought into question by this study. So toxicities, of course, completely expected. Toxicities are much more in the IV arm. I don't have to go into this, 25% versus 6%. Just to quickly go into the testicular involvement data from this study, 69 patients had testicular involvement. Among those with testicular involvement, 42% were actually in the low CNS IPI group, 36% in the intermediate CNS IPI group, and 22% were high-risk IPI group. The total CNS relapses among these 69 patients were actually only 12%, so very low number of patients. And 6 of these happened in the low and intermediate risk patients. Very little statistics you can do within this data because the actual number is only 8 patients. Quick analysis of this patient, of this paper from the editorial which accompanies it. So DLBCL CNS relapse rates about 5%. The risk may go up to 15% depending on which subgroup you're studying. The current guidelines give a prophylaxis for all those with a risk more than 10%. That is usually the CNS IPI. So what comes out is that we do need alternate predictors. The IT methotrexate were mostly treated with a DA epoch R. So whether this was a better and more intense chemotherapy with more CNS penetration, whether this was one confounding factor, but again, they adjusted for that in the analysis and they didn't find a difference. IV methotrexate mostly received R-CHOP. Of course, we can always harp on the fact that this is a retrospective study. And the number of patients who received IT methotrexate is almost 3 times or 4 times the number who received IV methotrexate. The imbalances are there across the groups, but this was again matched in the propensity score analysis. Not enough numbers for more analysis, but I think this is all that you are going to get. Again, final interpretation of this paper from the panelists. Option A, completely abandon CNS prophylaxis. Most studies show no benefit. Option B, at least IT methotrexate. Something, let us do something. We don't want patients to relapse in the CNS, so I will have the satisfaction of doing something. Or option C, I would still use IV methotrexate for whatever I have my own reasons. So quick take from the panelists. Which option do you choose? We'll start with Dr. Dinesh again.
Yeah, so we will do a lumbar puncture at the diagnosis and probably after looking at and reading this, do a flow also to say the CNS involvement at the diagnosis is there or not. Someone has a CNS involvement at diagnosis, is not a prophylaxis, then it is a treatment, and then you have to deal it with differently.
Yeah,
so someone doesn't have a CNS involvement at the diagnosis by this, and when you're doing a one IT, I would give a methotrexate also. Why to waste a one this thing? So we give a one methotrexate. There is no rush to give a IV methotrexate because we have a data to show it. So don't delay the treatment. So give a full R-CHOP. I will not give any prophylaxis in the low and intermediate risk, but high risk I will give it a prophylaxis, whether IT or IV. Testicular, probably yes, IV. Others, probably IT.
Dr. Ghanshyam.
Yeah, so my option will be option B.
Option B, IT methotrexate. Okay. Dr. Hari Menon.
I would give IT methotrexate. I would fall back now to give IT methotrexate wherever in high IPI score, a high CNS IPI score. But I would still stick probably with IV high-dose methotrexate for testicular lymphomas.
Dr. Rahul?
Yeah, so though still we don't know whether what we are doing is right or wrong. And as the patient moves around to the different places, I will stick to IT methotrexate without going to IV high-dose methotrexate. IT methotrexate is good enough with us. But yes, what is more appealing for me is to pick up in these high CNS IPI, various ways of picking it up, how we can pick up more diseases. Is there really disease which is present, or is there disease biology which is different, which is the question in mind? And Dr. Reena, I will again ask the question, in her so many large groups of people, and Hari and Dinesh, what has been, is there any specific group where you have seen which can peculiarly point out towards the disease biology leading to more CNS disease? Because it's just not had to do with IT methotrexate or IV methotrexate in terms of prophylaxis. It has to do with something with the disease biology which we are still not understanding it. Like R-CHOP, after R-CHOP, CNS involvement has really come down to a lowest level. Before R-CHOP, in an era of CHOP, there were high CNS diseases, but in R-CHOP, R particularly has brought it down. So that will be my research hypothesis to look forward. But right now, as we are into a private sector, research is very far away. We'll continue to give IT methotrexate.
Dr. Ritu?
Prasanth, I'll go for option B. And I also, if you permit me, I just wanted to know the general feel among the panelists that are we doing only CSF cytology, or many of us are doing also flow, especially with the high IPI, if we are supposed we have to plan. So how many of us are doing a CSF flow? I just like, if we just quickly, or everybody is doing a CSF cytology.
We're doing cytology only, but probably we should be starting to do the flow.
Dr. Reena, final word on the prophylaxis now.
The prophylaxis, I'm comfortable with ITMPS.
Okay. So I think that is a very clear message from all the panelists. So we give prophylaxis, we give IT. The data is very iffy, but we are all comfortable giving the IT with prophylaxis as of now. Ma'am, regarding question from Dr. Ritu, I think that's very important. How many of us are actually, we don't routinely do flow on the CSF, which we like to do based on the data, but ma'am, do you routinely do CSF flow whenever you are doing a CSF for a lymphoma?
So we've, kind of just about started. I don't have experience and I haven't looked at it really in the way to be able to comment on it. Definitely when patients come at relapse, we do the CSF and we do the flow at that time, because we want to know if they have CNS disease and to treat them accordingly. So, Ritu, I really don't know if we are making a difference, but we are, looking at it. Maybe in a year's time, when we have a little more data, I will be able to tell you that normal CSF cell count in how many patients we picked up. Like I said, if you look at the literature, it looks very nice. It's about, you will miss 60%. If you just do the CSF cell count, and the specificity for flow is almost 80%, 80 to, yeah, about 80%. So those figures look very impressive, but I have no personal experience.
Then what do you think, is it the rituximab which has brought down the CNS, or it is the IT methotrexate? I'm still not very convinced. I feel the rituximab has made a difference.
So rituximab does not cross the blood-brain barrier. It's a large molecule. It is the systemic control of the disease which has become more effective, and that is. And if you look at a large series which reports the lowest CNS relapse rate, it is, the randomized trial of CHOP and CHOEP 14 days and 21 days. So if you see in that paper, the CNS relapse is about 2.8%, which is the lowest, and there was no rituximab in that. It was just the dose intensity which made the difference. So I think that it is good dosing, and that's why we worry about high dose methotrexate intercalated between cycles, that we may be just pushing the backbone chemotherapy far apart, and we may do worse as far as progression-free survival is concerned, and end up with more patients relapsing. Otherwise, even if they don't relapse in the CNS, they may relapse in the nodal areas otherwise. So the IT prophylaxis, if at all you have to give, is important. If you look at large series, that they are giving to less than 5% of the patients, which means they're actually very selective about who is getting IT. And if you look at this series also, I mean, you have about 1,200 patients, you have 20 centers, and over 6 years, which means each center has been able to contribute hardly 10 patients per year. So it is, even IT prophylaxis, it may be 75% in this particular paper. But if you actually look at the number, I'm sure they're treating large volumes. These are all academic centers, and they have been giving it to hardly 10 patients per year, which means the role of IT MTX also is highly questionable in most patients.
Prasanth, I want to make one comment. We are carrying away with the message that IV methotrexate is out. There are a few caveats to it. This is a retrospective analysis. We may not get a prospective, but that doesn't mean the retrospective may not have the biases. The second, that mostly the people had received a DA-EPOC. So they have done a propensity score and done it. But considering it is a retrospective, probably we should collect the data. So now the majority of people are giving IT methotrexate in high risk cases. What is the rate of CNS relapse? If we collect the data, we'll have some outcome. But otherwise, if we just follow it and abandon the IV methotrexate, I'll have apprehensions.
But I think you have made a very valid point. I mean, whatever said and done, this was a retrospective analysis. So that questions will always remain. I think that is a very valid point. But let's just look at something more. So this again came out in this ASH. The full paper is not out yet. So we talked about large data, 1,200 patients. So now we have another paper of 2,300 patients. So we talked about a big data from the US. So this is big data from Australia, Canada, Europe, New Zealand. So these are like 2,300 patients from multiple centers. Again, looking at a very similar question. They are not looking at IT versus high-dose methotrexate. They just looked at high-dose methotrexate versus nothing. And they, again, without going into too much of the detail, they claim that this is the largest study investigating the efficacy of high-dose methotrexate in reducing CNS relapses in high-risk patients. And they again come out with this data that high-dose methotrexate was not associated with reduction in CNS relapse. We don't have a lot of analysis here yet because this is only available in an abstract form as of now, but I'm sure sometime down this year, we will see the full paper of this. And again, we can debate that later. But again, very similar numbers here, 9.2% with prophylaxis, 8.1% without prophylaxis, absolutely no difference. Let me show you one more data. Again, very big data. This is from one center from Alberta in Canada. So high-dose methotrexate, they were consistently using for patients this was a recommendation for patients with elevated LDH, ECOG more than one, and more than one extranodal site. So not everybody received it, but many of them did. So this was 906 patients. Again, looking at the data, just look at the bottom right-hand corner. With prophylactic high-dose methotrexate versus without prophylactic high-dose methotrexate, this is 115 patients, 11% versus 12%. Again, no difference in the CNS relapse risk. Again, consistently, many more studies are coming out with the data that adding a prophylaxis with high-dose methotrexate does not improve or reduce the risk of CNS relapse. This is data from Memorial Sloan Kettering, 585 high-risk patients eligible for prophylaxis, 5-year risk of CNS relapse with prophylaxis 5.6%, without prophylaxis 7.5%, IT-MTX 5.6%, IV methotrexate 5.2%. Again, showing that there was probably not much of benefit. Again, clearly showing no difference between IT versus high-dose methotrexate. This paper did suggest that prophylaxis probably delayed the relapse rather than preventing it. So this was one of the things which came out. But the total numbers are smaller than what you saw in the other few papers. So it's not just one data. There is a lot of data. So the editorial accompanying the blood article that we've been discussing till now, they summarize all these major studies, and many of them have come out in the last couple of years, 2019 to 2021, and consistently all these studies show that other than this one study which I put in green, all the studies have shown that there was absolutely no difference whether you gave prophylaxis or you did not give prophylaxis, and there was no difference between IT, MTX, and high-dose methotrexate. So this one paper stands out, but there is multiple other papers, and there is this meta-analysis also which came out last year. I'm not sure that all the papers that we discussed have gone into the meta-analysis, but the meta-analysis again shows no significant difference in the CNS relapse whether you received CNS prophylaxis and you did not receive CNS prophylaxis. So again, the general message from all this, not prospective studies, they're all from retrospective data, seems to suggest that there is not much of benefit the way we are doing the CNS prophylaxis now, or we are not choosing the patients correctly to give CNS prophylaxis. So this is what is emerging from available literature as of now with all its caveats. So again, one last question before we go to the last couple of slides. What is the overall data on the basis on which we are delivering prophylaxis in DLBCL from all the panelists? Is there a strong data to give? Is there a strong data not to give? We feel there is no data, but we should give, because for the high risk, because the guidelines say so. I don't know if DLBCL relapses, I cannot do much, especially in CNS, so we do the best possible. You cannot generate evidence for every scenario. The data against giving are all retrospective, like Dr. Dinesh mentioned just now. I don't believe this data, so I will continue to give. So where are we here in this 5? Where are we right now? Just to give a message to everybody. What is the basis of what we are doing?
Shall I start?
Yes, yes. Sir.
Okay, so I mean, at least there is a data to, I mean, we have a more comfortable data. Not giving IT or IP, you're not doing a much of a difference. So definitely no for no risk, low risk and intermediate risk. High risk, I would continue to give. Whether to give a IT or IV, if there is any risk of some, definitely the testicular, I would keep giving IV, otherwise IT.
Dr. Hariman?
So I would just say, be discerning. It's not yet time to completely dump intrathecal methotrexate or high-dose methotrexate, but we use it discerningly in, as Dinesh rightly pointed out, in the high-risk patients discerningly. Otherwise, yeah, I will say that the need for using intrathecal or high-dose methotrexate has really shrunken after all this data, which has been more or less consistent in its in what it has to say.
Do you think that is it feasible or is it necessary currently? Suppose somebody wants to do a study of DLBCL, let's use high-risk patients who are receiving RCHOP. One arm I give IT, one arm I don't give IT. Is such a study even feasible, or is it necessary to do such a study? Dr. Reena, ma'am. That should answer all the questions that we are once and for all.
In real world, getting some of these studies going is very difficult because people have such strong my gut feeling. But if you leave testicular lymphomas out of this group and you just take the regular, and let's leave the high grade lymphomas, you take now what we say de novo, DLBCL, NOS. I would be happy to be a party to something like this and actually once and for all prove that the ITs have not worked. So IT versus no IT is the first question that actually needs to be answered. And after that, we have kind of answered that there is no difference between the two. So if we can answer that, we would make a meaningful difference to a lot of patients. Having said that, again, if you look at the number of patients who are actually getting the prophylaxis now in DLBCLs, it is greatly reduced. So as compared to earlier, earlier almost if you look at your patients, either they had bone marrow involvement, or they were B symptoms, or they were high LDH, or they were high stage. And so for some reason or the other, you could give it to everybody. And which means more than 50% patients in the Indian practice, I'm sure, at least in my institute, it's about 25% still, which I want to bring down to as it is in the Western world, which is less than 5%. At that 5%, you will need a very large trial. The numbers will be huge. I don't know if it will happen, but those are the only 5% patients in whom I will still, say, okay, though I don't have data for these, I will give it to them. The rest, I think we are convinced that we don't really need to give too much of IT.
Madam, we can make a Prasanth leader for this trial.
Yeah.
Yes,
we
Prasanth
can decide now itself, be part of it, and Prasanth can lead it.
So, Prasanth, I'm willing to give you all my data. I have more than 600. When I did the analysis, it was 600. Now it's 832. And if I put in another 2 years, I'll cross 1,000. So those patients are yours to analyze. You already have done the literature survey. So you can choose from other sites and we can give you all the data together. Only what we'll have to actually do is to see how many of these are non-evaluable for response and who have been lost within 1.5 years, and see what statistics we need to use to say that what is our actual true CNS relapse. We may be showing it lesser than what it is because we don't know what happens to about a good 12% of our patients.
I'll just, there are some alternate predictors of relapse. I don't want to go into too much of a detail. There is now recent data emerging. You can use some molecular predictors for relapse. There is some data that you combine the cell of origin with your CNS IPI and you get a better predictor of relapse and all those things. But all these things need further validation. So this is just some suggestions. And some more things which seem to be emerging, that a very aggressive regimen can probably reduce the overall risk of relapse. So this is some data using the ACVBP regimen. And the 3-year CNS relapse was 1.6% with ACVBP as compared to 4% with R-CHOP. So when your regimen becomes more stronger, then maybe the CNS relapse overall comes down. So this is some food for thought. Again, these are some early data. Again, this is something which came out in the last year. Similar data in that Alberta, Canada data that I showed, they found that those who got consolidative autologous transplant, I'm showing the bottom part of the screen, those who got consolidative autologous transplant, the incidence of CNS relapse is 6% compared to those who do not get autologous transplant, where it was 13%. Again, some suggestion that the more intense your primary treatment is, that can also bring down the CNS relapse. So just to give some take-home message from my side based on what we discussed, and I think Dr. Uday will have the final word on this. So there is a group of patients with DLBCL with high risk of CNS relapse, probably identified by high risk CNS IPI, plus or minus ABC subtype, DHL, some genetic profiles. All these things are not available in the clinic. Testis, bone marrow, query, breast. So CSF is negative at baseline, but positive by flow cytometry. We should do something to reduce the risk of relapse. The data seems to suggest that ITMTX may not help, IVMTX may not help. More aggressive therapies in first line may help, but are we ready for this? Probably no, because on the whole, nothing seems to be better than R-CHOP. But the message that I gained from this, that despite all this data that is staring at us, we would still do CNS prophylaxis for some groups, particularly for testis involvement, for example. Some of the patients be selective with high-risk CNS IPI, somebody with a double-hit lymphoma, for example. So this is where I leave this. And finally, I think, the RCHOP still stands. Nothing seems to shake the RCHOP, so he continues to laugh at everybody else. So this is my last slide for the day. I'd like to take this opportunity to thank all the panelists for a great discussion and a very difficult topic to go through and come up with. And thanks for sharing all your experiences. And thanks particularly to Dr. Reena for so much. I learned so much, man. Thank you very much. And thanks once more to Dr. Purvish and Dr. Amish for giving me this opportunity. Thank you very much.
Thank you, Prasanth. Fantastic job of moderating this very important topic. And now we move to the third professor who's going to give our experts, and that is Colonel Uday Yanamandra. I have a fondness for the men in uniform in the Indian Army, so salute to you, Dr. Uday. Just as your predecessors, you are also a very prolific researcher and a teacher par excellence. And I think that goes for all the three of you. Because of this high level of discussion and intense debate about what is going on, you have a very difficult task, I know, but you are up to it, because high level and high altitude is your forte, right? In the API's textbook of medicine in the 11th edition, you have written an entire textbook on high altitude medicine. You have also received the Chief of Naval Staff Award for the best research, and you have so many publications in your relevant journals. Besides, I know that you are spearheading the IMAGE, or the Indian Multiple Myeloma Registry, and like Reena was doing for lymphoma, you have a large number of patients that are in your registry with multiple myeloma. So with this brief introduction, over to you, Dr. Uday, for expert conclusion and way forward.
So can I share my slides, please? So firstly, I would like to thank Dr. Purvish for giving this opportunity and asking me to wrap up the whole thing. But this is like if the opening batsmen have already played the full match and the last guy coming only for the last over, something like that. So Dr. Reena and the panel and Dr. Prasanth have almost done the whole job of it. But I'll quickly wrap up the take-home messages for the benefit of the students. So the first question is, do you agree with the views of the interviewee? So I couldn't agree more. So I totally strongly agree with whatever ma'am has said, and there's nothing to comment against about the views of the ma'am as far as this topic is concerned, because this is her forte. Now, will you change your practice based on the discussion today? Yes, certainly we will. And there are a few points which I have tried to jot down during the discussion. So can we identify the high-risk CNS disease, which has been discussed aggressively by Dr. Rahul Bhargava and has been discussed by the panelists in detail? So CNS IPI still only picks up around 10% of the patients who develop who have a risk of relapse, CNS relapse. As ma'am has reiterated, trying to do flow cytometry on CSF at diagnosis can really help most of us, which most of us are not practicing as on day. We are just relying on cytology. So if most of the centers can start doing this, we might be picking up those patients who have got occult disease as far as the CNS disease at the time of diagnosis of these DLBCLs are concerned. Now, the newer things, that is activated B cell subtypes, the double hit, the distinct genetic signatures, most of them are still the research topics as of date. And if we look at a real world scenario, many of the patients might not be affording for doing these tests, but yes, most of the academic institutes can still do it. But despite of all these things, as has been discussed extensively, the fact has been the prognostication has still been disappointing, and we need proper research in this direction to actually identify those 5% of these patients who have a high risk of developing CNS relapse. How will I stratify my patients for the CNS prophylaxis? So the CNS IPI has come up as a good tool as far as for identifying these patients are concerned. These are the various risk categories which have already been enumerated by Dr. Prasanth in his discussion. And as has been told, these are the various conditions irrespective of the CNS IPI, particularly the testicular lymphoma, the high-grade B-cell NOS types, the primary cutaneous DLBCL, the breast lymphoma. Tonsillar was one thing which Dr. Rahul was saying that he would definitely love to give prophylaxis, whereas ma'am held back her statement by saying that that is one place where she will take a step back, she will think about it and go ahead giving the CNS prophylaxis in these individuals. HIV-associated lymphoma is one thing which was not discussed, but is one place where we will definitely consider giving a CNS prophylaxis. Now, the next question, the take-home message for the students: would you still give CNS prophylaxis? Yes, all the panelists definitely agree to the fact that yes, they would like to go ahead and give CNS prophylaxis and not dump it as of now in these patients who have got high CNS IPI risks. And why we should give it, which has been brought out by the interviewee as well as by the panelists. The foremost thing, it has got a devastating prognosis for those people who develop CNS relapse. And particularly in our settings, in Indian scenarios, when a patient comes back with CNS relapse, it's almost like a death statement, because not many patients can afford the therapies which Dr. Rahul was trying to enumerate. There are no laid down clear-cut exact management protocols which are universal in the country or which are national guidelines. Every institute does its own, and everybody have their own experiences as far as CNS relapse is concerned. Like our experience has been atrocious. We have not had a single patient who survived with a CNS relapse. Many people have tried adding the IMiDs, the BTK inhibitors, the venetoclax, whatever is newly available for adding up for treating these patients, both for prophylaxis as well as for the relapsed patient. But again, the data is very immature or immature. Now, specific to Indian settings, the IPA or CNS status at diagnosis is not known in many of the patients, despite of our discussion going very high level about trying to pick up the patients. But the truth is, most of these patients get diagnosed at a second level or a third level CTs, where the people already get some therapy, and by the time they come to these academic institutes or a tertiary care levels, they would have received 1 or 2 cycles, and none of us know what was their actual IPI status. In fact, we were trying to fish out the LDH of all the DLBCLs from PGI Chandigarh, and let me tell you, we couldn't get even of 10% of these patients. So that's the hard truth as far as our country is concerned. Now, many of them are not being properly evaluated as far as the type of the cell type and other things are concerned. So these are important for all the primary physicians to understand and to evaluate at baseline about the CNS status, IPI, and the molecular markers as far as possible. Now, primary therapy compliance, as Madam has very categorically said, it is the backbone induction therapy which plays a major role when compared to what type of prophylaxis are we giving. So, if a patient can be maintained on a compliant primary therapy without any interruptions of the therapy in a real world setting, that would actually prevent most of the CNS diseases more than the intrathecal or the IV methotrexate. This has already been brought out, the various major studies, including CNS prophylaxis. And finally, what was told was, if we choose between IT methotrexate and IV methotrexate, most of us would like to go ahead with the intrathecal methotrexate rather than IV methotrexate. Before this particular session, I was very much in favor of giving DA-Epakar, but after this last 1.5 hours, I've changed that it's R-CHOP equal to DA-Epakar, or actually R-CHOP better than DA-Epakar in those patients who have got a high-grade lymphomas. Coming to why IT more than IV in Indian settings: less hospitalization, no strong data to support the superiority of IV methotrexate. Now, handling toxicity of IV methotrexate, of what Dr. Prasanth has very beautifully brought out, the various toxicities of IV methotrexate. In Indian settings, managing any of this toxicity is a nightmare. Hospital-acquired infection and the cost involved for hospitalization, or as well as additional days of treatment in the hospital for this IV methotrexate, can actually pinch the patient's pocket heavily. So IV methotrexate only in certain situations, as has been discussed and as has been brought out here. This was what was talked about. Ma'am was commenting about intercalated versus end-of therapy, and also in the chat box, I could see many of the people trying to write about meningitis, the IT methotrexate induced meningitis. Why not give it in the center? Why not give IV methotrexate in the center? So, as has been brought up both by Ma'am as well as by Dr. Prasanth, so it can actually delay the primary therapy. It can increase the toxicity, and there was no difference in survival of intercalated versus end-of treatment. So preferably push it to the end of treatment than compared to intercalated. Again, this is something new which I was not doing till now and which I would like to follow henceforth. So these are the various take-home messages that we have. So Before this talk, I thought that the new way is different from the old way, but now I would feel no, the old way still remains the best way. So the new way and the old way is still the same. Thank you.
Thank you very much, Dr. Uday, for a wonderful wrap-up. And I think it's your experience and insight that allow you to do such a fantastic job. Now I'll hand it over back to my co-program director, Dr. Amish Vora, for the concluding comments. Over to you, Amish.
Thank you, sir. Actually, this paper is written by who's who of USA, and I'm so honored that we learned so much from who's who in lymphoma in India. And my personal and sincere thanks to Uday sir also. You wrapped up, the commitment towards the expert comment, it moved me a lot. Thank you so much, sir. And thank you. I think we learned a lot today. As Dr. Prasanth said, was there much practice changing? I think, Prasanth, we learned a lot. With that, I would like to conclude, and I would like to say that thank you so much. Please keep encouraging us. Please giving us feedback, remarks, whatever you feel like doing, but please do write to us. The next OBTO is 8th of March, the same date like today, and 8th of March. And we are discussing one more topic of keynote 826, that is pembrolizumab in the first line in cervical cancer. Cervical cancer, disease of the poor countries, but pembrolizumab is very expensive. Does it really make a difference? As FDA has approved it. Thank you so much. Please join next 8th of March 2022. With that, we can wind up this session. Thank you so much, everyone, for joining.
Thank you. Thank you very much.